Okay, I think we're now live. Over to you, Tracy.
Thank you very much for that, Katrina. So thank you very much to those of you joining us live for this stream today, for taking some time out of your busy schedules. You're all very, very welcome. And thank you to those that will be joining us later, watching this via catch-up. My name is Tracy Cripps. I'm Vice Chair of the BAME Network. And together with my co-Vice Chair, Emil Brown, we will be chairing this session today with Dr. Sani Aliyu as part of our Black History Month programme of presentations we've been running all week. And I hope you've managed to participate in some of the other sessions. When Erica, Emil and I, as the leads of the network, were sitting down several weeks ago now, sort of planning this agenda, actually, Dr. Sani was the very first person, and Emil, you'll remember this. I said, I want Dr. Sani, that came to my mind. And, you know, that there was a very deliberate reason for that. I was privileged enough, actually, to hear one of Dr. Sani's previous presentations that he gave, where he spoke about the magnificent work that he did in Nigeria, where he set up a government task force to lead the response to the pandemic in Nigeria. And actually, I've no doubt in my mind, if it wasn't for Dr. Sani's contributions, you know, an enormous amount of lives would be lost, and he did some incredible work there. So Dr. Sani, the BAME Network actually today, particularly Emil and I, we are absolutely honoured and delighted to have you with us today. I will take nothing further away from your careers discussion, and I hand you the platform now, really. So welcome, Dr. Sani Aliyu.
Thank you. Thank you, Tracy. Thank you for the kind words. It's to be honest, the honor is all mine to be addressing you this afternoon. I do have quite a number of slides, but I'll try and keep to time. We'll try and keep at least 20 minutes towards the end of the talk. If I'm going too fast, please just let me know, because I tend to speak very, very, very fast especially when I start getting a little bit anxious about time, etc. So here we go. I'm just going to share my slides, and apologies if I keep on coughing in between bouts of presentations. I do have a cold that I'm trying to shift, but it's not COVID. And it's not infectious virtually either.
I'm just glad you're here, Dr. Sani. Thank you for making the effort.
Okay, so I'll just see if you can see. Can you see my slides now?
Yes, we can.
Okay, brilliant. Okay. So I was asked to talk about my career progression in the NHS and really my experience over the last 4 years or so abroad. I will take you through a little bit about my background, and then the 2 opportunities I had to work abroad, what I have learned from my leadership journey, and what I believe the NHS can offer, and the sort of benefits the NHS can get from similar opportunities. So I originally come from Nigeria. I did my medical degree in Nigeria, finished in 1993. So for those of you that are mathematicians, you probably would realize that I'm just on the wrong side of 50 or so. I came to the UK in 1998 to do a postgraduate program at the Hammersmith. And then I went on to do my master's at Queen Mary, and I did my membership exams, licensing exams, and started off as an SHO in UCL in 2000. In early 2001, I came over to CUH to start off initially an SHO job, and I was subsequently successful and started training in microbiology and infectious diseases. I was the first joint trainee, so in a way I was really the guinea pig for the training program, and this was in mid-2001. I'm quite proud that a lot of our trainees are now joint trainees. They're training in both specialties. In the past, it used to be separate, and I think it's just, I guess it really shows how successful the the training program has been over the last 5-10 years. I finished my training in 2007, briefly went on to Birmingham for a year as a consultant, and CUH advertised for the first joint consultant in microbiology and infectious diseases. I applied, I was successful, and I came back to Cambridge in July 2008. So effectively, I have been in CUH or part of CUH at least for the last 21 years or so. Part of my role also includes being a Caldecott guardian responsible for issues to do with patient confidentiality. And I became the Caldecott in 2015. I had two opportunities to work abroad. The first one was in 2016 or so for about 3 years, and the second one was in 2020. So, of course, it hasn't been a very easy period. When I came over to the UK in 1998, I had the usual challenges that people from the diaspora would have: the change in environment, dealing with a different culture, trading and doing exams while at the same time having to deal with a young family, issues to do with time management, etc. But I must say the CUH was really the ideal learning ground. It was a very friendly environment. It was a steep learning curve, but I had tremendous support. I had what I usually refer to as enablers, people that have supported my career right from the beginning. Mentors like Andrew Lever, who still works in infectious diseases, the late Regius, Patrick Sissons, Hugo Ludlam, who was in microbiology, etc. A lot of people. And I've, over the years, developed really good relationships and friendships that I continue to value. So just a little bit about Nigeria before I tell you what I actually did there. So Nigeria is in West Africa. It's a large country. It's 3 times the UK, both in size as well as population. About 1 in 6 people, Black people in the world is a Nigerian. So there are quite a lot of us. It operates as a federal unit, very similar to what you have with the United States. It has a very rapidly growing population. The median age, a very youthful population as well. The median age is 18 years. Rapidly growing, that we have 9 million births every year, so almost twice the size of some of the smaller European countries in terms of birth. It also has the dubious distinction of having the largest number of babies born with HIV, the 4th highest infant mortality rate in the world, and the most number of children out of school. 10 million kids are out of school. There's a huge disparity when it comes to health outcomes as well as wealth. Significant variations when it comes to access to health services. The urban areas are relatively well resourced when it comes to private hospitals, etc. But with the rural areas, there's really very little. The life expectancy is 55 years. So if I was in Nigeria, I would be sort of tidying up my things and getting ready for the great beyond. So just a bit about HIV. People always ask me, why is it that HIV is so important in public health? We don't hear of other disease conditions the way we hear about HIV. Well, the main reason is because HIV affects the most productive part of the population. It affects relatively younger people and people in middle age, people who usually go out to look for money and to look for bread for their family, etc. In other words, the most economically productive part of society. And that's why HIV has such a huge socio-economic impact, very similar to what we see with COVID. And it's not just the health issues, but at the same time, it also has a significant impact on life expectancy. So this is a graph showing from 1950 onwards, most of the developing countries, including Africa, showed a progressive increase in life expectancy right up to the early 80s. But look at Zimbabwe, for instance, with the red line. They peaked at around 63 years life expectancy in the late 70s, early 80s, and just see how how steep the drop was in life expectancy, right up to almost 40 years. And this was primarily because of HIV. But what we know is that with the advent of HIV treatment now, things have changed. People are now able to live a healthy life, and if they're going to live to be 80 without HIV, they will live to be 80 with HIV, provided they take their treatment. So access to HIV treatment is so crucial when it comes to preventing AIDS and death. So my first time out was in July 2016. I had a call from the Nigeria government. At the time, there was an election in 2015, so it was a relatively new government. They had come in and were trying to tidy things up. But they had a major problem with the HIV program. The agency responsible for running the HIV program in the country was the National Agency for the Control of AIDS, NACA. And this was an organization that had become really very dysfunctional. They had fallen out with their major donors. Nigeria had been suspended from the Global Fund program. And with the second largest HIV epidemic in the world, clearly they were in trouble. So they reached out to me and asked if I'll be happy to come over to head NACA as the Director General and help to sort out these issues, particularly the issue of conflict with donor partners. And I wasn't the only person who was approached. They did approach other professionals in the diaspora in the US and UK to head other parts of the health sector, like health insurance, etc., and the primary healthcare agency. I wasn't sure why they approached me, but anyway, I thought about it. And to be honest, I had always been looking for the opportunity to pay back because even though I attended a private primary school, but my secondary school and university years in Nigeria were all free. My parents didn't have to pay anything for me to get a degree. So in a way, I really felt that I needed to put back into the community that had helped to make me what I am today. But I was also quite cautious because my working experience in Nigeria was quite limited. I left as a junior medical officer. I was used to working in the UK environment where most of my career, I'd spent most of my career life. And I was really worried that I'll go there and just get messed up because I knew the issues in Nigeria. So just a bit about NACA. So NACA is in Abuja. The headquarters is in Abuja. It's not a huge organization. It has a staff strength of just over 300. But it's very heavy, top heavy in terms of the director cadre staff, 42. They have 42 director cadre staff. And when I say for director cadre, I mean assistant directors, deputy directors, and directors. So quite top heavy. It had a small federal government budget of just $3 million annually, but a huge global fund budget of about $110 million US dollars every year, and also funds coming from the US government. One of the advantages of NACA is that it does not report to the Ministry of Health. It reports directly to the presidency. So even though it was a small agency, because of the amount of funds that come in and the fact that it had such strong influence on the HIV program, and the fact that it reports directly to the president made it a target, so to speak, of people who probably wanted to enrich themselves, etc. It was also a first port of call for every HIV-related issue. But politically, it was really well known in Nigeria because the politicians were always trying to get their hands in the till. So the appointment process was not without its challenges. In the first instance, I didn't apply for it. I didn't interview for it. It was a very high-profile post, very competitive in Nigeria. And I was relatively unknown in the Nigerian civil society, especially within the HIV civil society. Nigeria has a very vibrant HIV civil society, people living with HIV. It has numerous associations and networks within the society, and they are very vocal. But the advantage I had was I had a twin brother who we went to medical school together, and he was a professor of public health in Vanderbilt, and he happened to have spent a lot of time delivering treatment programs through his university in Nigeria, through his US university in Nigeria. So he knew the HIV network and the people very well. So in a way, it was almost like they were dealing with me. And I found that relatively easy. They kept on saying, oh, we thought it was this person. But at the same time, it meant that I had somebody who could pretend to be me. The great pretender, I call him. So this is a picture of the two of us. The person in the middle was actually the Minister of Women Affairs. We were attending an International AIDS Society meeting in Amsterdam. And some of my staff who were there at the meeting were continuously confused whenever they saw him and saw me together. They just couldn't work out who was who. So in terms of the operational environment, I've mentioned the reporting structure, which was an advantage for NACA. But the Nigeria working culture was very different. It's very hierarchical. They operate quite a closed-door policy. You don't have access to your staff easily, except for your top directors, and expectations never really matched with reality. And of course, navigating the local politics, the terrain was really a challenge. So in the early days, initially when I was appointed, I had to negotiate with CUH, and I'm very grateful to Cambridge for allowing me to go. And they allowed me to go initially for a year and then extended for up to 3 years, although I was still coming back to Adam Brooks to do some clinical work on the wards, just to keep my skills up, which was unpaid. But it took a while for me to get to Nigeria. Obviously, the Nigerian government wanted me to just drop everything and go, which was not possible. In fact, it took about 6 months. I got there in January 2017, although I was still traveling to and from Nigeria to help with things until I moved over completely. And before I resumed, there was a lot of negative press in the reports that the government had taken up, given diaspora appointments, and these people are not ready to come and start working. It's taken them months. And the external donors themselves were quite concerned that there was a gap that existed that really needed to be filled. But one of the challenges I also had was that of conflict of interest. Virtually every person you meet had his or her own agenda. So for instance, there were donors that were more interested in giving the country loans for the HIV program so that they can make money out of it. I will not mention them, but these are multilateral institutions, big multilateral institutions. There were donors that wanted the number of people on HIV treatment to be huge so that they can continue to have their grants, etc. And of course, there was a civil society with all their issues. So it wasn't easy at all. But what I did have was support right to the very top, a commitment that they really wanted things to change. So I knew I had a maximum of only up to maybe 3 years at most. And I thought, well, the best thing is to identify my priorities. And I thought the 3 priorities that I could deliver within the time frame would be a restructuring of the organization and a complete review of the HIV program in the country, establishing the true prevalence of HIV, because I just didn't believe that we had 3.2 million people living with HIV in Nigeria. All the data did not really match with what was on the ground. The implementing partners were finding it very difficult to identify, diagnose, and put people on treatment. And then thirdly, a situation where the majority of HIV funding was coming from external sources was really not acceptable. We had over 1 million people on treatment. More than 80% of them was being funded through the US government. If the US decided tomorrow to just up and leave the country, we will be left with over 1 million Nigerians coming off HIV treatment. And that cannot be right. So I went around, spoke to a lot of people, and then sat down and I did my wish list. And essentially it reflected the 3 priorities: the need to streamline the NACA as an organization and restore relationship with donor partners, as well as public acceptance and goodwill, and the need to know exactly what the true burden of HIV was in the country, and also have a new pathway for achieving epidemic control of HIV by increasing the number of treatment centers, by putting more people on treatment, and improving access to prevention of mother-to-child transmission services. I also thought that it was not right that HIV treatment services were mostly driven from tertiary and secondary healthcare centers. What you need is for them to go right down to the community, to the primary care level. And of course, having a sustainable and more durable arrangement for funding. And fortunately, the president on World AIDS Day in December 2016 came out with a specific directive And he essentially, what he said was, we need to make sure that NACA's vision, mission, and values align to its mandate. So this was a presidential directive. It came just before I fully resumed in January 2017. And everybody aligned to this. It was really very helpful, because being a very hierarchical society, the moment the president says, I want this done, everybody falls in line. And it really helped my job significantly. So first priority, wanted a new governance structure. What did I do, or what did we do? Because this was all teamwork, really, to be honest. So I introduced a staff appraisal system and a 360-degree feedback. And surprisingly, none of the directors had a proper appraisal in the past. None had feedback. They had absolutely no idea whether they were doing well or not. And we then, after the appraisal, which I did myself with the 42 directors, each one on a one-to-one basis, we then matched their skills with the responsibility. We removed duplication of services. We merged departments. So the organization contracted to just 5 departments and 5 units. And we created a new department for performance monitoring and resource mobilization. I decided to open 6 new zonal offices across the country to decongest the center. And I was able to secure a permanent office from some of the empty government buildings we had in Abuja. They had been renting for more than 10 years at considerable cost to the taxpayer. So we had a brand new building, which was a permanent office. And in addition to that, I worked with the civil society networks, and we created a single coordinating entity for HIV, a single one-stop shop where all the associations of persons living with HIV can come to, and I only had to deal with one voice. So we did priority number 1, done. Priority number 2, wanted to know what was happening with HIV. So as I said, the claim was that there were 3.2 million people with HIV, and that couldn't be true. We worked very closely in the first 6 months of starting with Global Fund and the US government and some other partners, and were able to resource $105 million to set up the largest, what is currently the largest HIV specific survey ever done in the world. This was huge. We had a team, 190 teams across the country. We used more than 380 vehicles. We set up more than 100 mobile labs, each lab receiving about 200 samples of blood every day. And our teams went around close to 100,000 households and sampled more than 220,000 participants. So the survey was done very similar to the other population-based surveys that were done in other parts of Africa a few years earlier. But with the other African countries, it was taking them a year to plan, a year to do, and a year to deliver. I didn't have 3 years to do a survey, so we just pushed it. And I was able to get the president, that's a picture of him in a flowing traditional gown, to personally launch the survey at his office. So that's me in the middle. That's the US ambassador. He's shaking hands with the US ambassador to Nigeria, and that's the Minister of Health by the side. And getting him to launch the survey really helped because all the friction and the aggression and the resistance had to go away. And this was how the survey was done. It was done in waves. We had 6 waves. We would take 6 or 7 states at a time and do a wave of sample collection. And we received the reports, the progress reports, on a weekly basis. And you can see that in terms of households, we were able to access 87% of the households we wanted to. But one interesting thing was we thought that each household had about maybe 4 to 5 persons per household. And of course, we were wrong. You'll go to a household and you'll find 20 people. So at the end, we exceeded the number of participants we enrolled, even though we went to fewer households. And people were very happy to have their bloods taken. We thought that our target for blood draw was 77%, but actually we achieved 93%. People were very happy, including children, to have their bloods taken. And we did establish the true prevalence of HIV in Nigeria. We published this. It turned out we didn't have 3.2 million people. We had between 1.6 to 1.8 million Nigerians with HIV. And if 1 million are already on treatment, it means the gap, the treatment gap is much, much narrower than we thought. And this was what we used to go on a strategic advocacy drive with the donors and say, right, it's now reachable. It's now possible for us to achieve the 90-90-90 targets for HIV epidemic control. The 90-90 targets are 90% of all HIV patients identified, 90% of those identified are on treatment, and 90% are virologically suppressed. And before the survey, there was no hope of ever reaching the 90-90-90 targets. It was just a goal that was not achievable. Suddenly, things were possible, and it looked like we'd be able to achieve epidemic control. And the US government, I must say, were very supportive. We were able to restore our full relationship, and they started off with a surge, and we started putting people. We knew where the people were with HIV. We knew where to get them, and we knew how to put them on treatment. And additional resources were put in. And last year alone, the US government put 350,000 persons on treatment in a single year, not even with Global Fund. And in the last, we anticipate that in the next 1.5 years, Nigeria should be able to achieve epidemic control of HIV. And it just shows the importance of data. Without data, you really cannot do much when it comes to public health. The third priority was to secure a sustainable funding pipeline. And here we're talking about how do we get money that we can continue to pay for treatment. And most of the expense really comes from commodities, but also from infrastructural issues, etc. And if the government of Nigeria was to pay for all HIV services, it will consume more than 60% of the federal health budget. So it was a non-starter. So what did we do? We approached the state governments and said, look, put aside 1% of your monthly federal allocation so that you can have your own HIV programs as well. Fortunately, they agreed, even though only some of them have actually actioned this. We were also able to get HIV as part of the indicator diseases on the health insurance scheme, the National Health Insurance Scheme, after a lot of hard work and pushing. And one thing that we did, which was a bit cheeky, I think, in retrospect, but I was approached and asked to write the speech for the Nigerian president at the UN General Assembly, because there was the UN General Assembly in September 2017 2018 had a HIV theme. So I was asked to write the HIV section. And I thought, well, what do I want him to stand up and say? I would like him to say that he commits to putting 50,000 additional new patients on HIV treatment every year. And my staff said, oh, sir, don't do that. His minders will remove that passage. They will not allow him to say it. And I inserted it, and they didn't. Maybe they didn't notice it. But anyway, he stood up, he said it, and suddenly it became policy. So because of that, the funding to NACA increased in 2020 from $3 million to $14 million, because everybody said, this is what Mr. President wanted, and it has to be done. We also worked with the private sector to set up a HIV trust fund. The actual launch has been deferred to late 2021, but we already have a commitment with a $50 million seed grant. And I currently sit as a trustee on the HIV trust fund. And the last thing I did, which I think was the clincher really, was to get presidential approval to remove all middlemen from the HIV market. In the past, if government was going to buy drugs or going to buy test kits, they will have to give out a contract. The contractors will go to India to buy the generic drugs. They will put their 30% profit on top, and fewer people will get treatment with the money that we had. So I was able to get that removed, and now the government buys directly from manufacturers in India. And we eliminated the profit-driven purchase of commodities. We got that done just around the time I was leaving NACA, and my successor really got into big trouble with the with the private sector because they just went after him. They thought he was the one that started it all. In actual fact, it wasn't his fault, but I think it really made a difference because suddenly, with the additional funds that we now have, we're able to put a lot more people on treatment for HIV, and that's a picture of the head of one of the large banks, Access Bank, and the head of Texaco, an oil company in Nigeria. They were responsible for setting up the HIV Trust Fund. So I thought everything was done. I need to get back to Cambridge. So I went, saw the president, thanked him for the opportunity, and bid him farewell. But I didn't realize that this was not for long, because what happened? COVID broke. I came back to the UK in July 2019. March 2020, less than a year later, I was back in Nigeria. This time around, I went for a visit around the time of COVID in March 2020. I had tea with the leadership, and not with the leadership, but with his office. And I was asked a number of questions about how they should manage the COVID pandemic. And my advice then was really that they need to set up a task force, very similar to what the US government have done. And I knew Nigeria could handle it because they've had experience of managing Ebola. They have a relatively skilled manpower, and the level of health infrastructure was not really that bad compared to other African countries, especially if you look at the urban areas and the private sectors. So the task force was set up. The Presidential Task Force on COVID had 9 ministers and the chief executives of the Nigeria Center for Disease Control, the equivalent of our PHE, and the chief executive of the secret police. In retrospect, I just kept on wondering, why did we have the secret police on our committee? But they were quite useful when it came to lockdown, etc. They knew how to do it properly. We also had the chairman, and this was the head of the most senior public servant in the country, and the WHO country director. And I was asked to come in as the national coordinator responsible for heading and running the secretariat. And again, CUH were very generous to allow me to go once again, having been back for barely a year. So COVID was really challenging. We set up an incident management structure. Initially, we had daily meetings going through the nights and weekly presidential briefings. This is just a picture of one of the presidential briefings we had. But over time, things got better and the meetings got less frequent. The decision making was fairly quick, and we set up a scientific advisory group. I reached out to colleagues and friends I knew in the UK and the US. We set up what they call a Tuesday meeting group. It was a scientific advisory group with very clever people from Imperial College, from UCL, and from Harvard. And they did all our mapping and provided us with advisories. And interestingly, those in the UK were involved with some of the SAGE decisions that were taken in the UK. But the difference was that we acted on the briefings immediately. Whereas with the UK, I must say, it took a while so the international travel, for instance, some of our restrictions and our policies for travel, we did it at least 2 months before the UK government did the same thing. So when COVID broke, we locked down the country in late April for about 5 weeks. And it was very effective, as you can see from the bottom graph. That's a mobility graph showing the change in movement. And you can see right down to up to a 60% drop in movement. And it was very effective, really, especially for some of the states. But towards the end of the 5th week, we had trouble. From the perspective of what went well with COVID, when I compare it to HIV, maybe because we had a lot more resources and we were running an emergency situation, we were able to do a lot more. So we activated 131 treatment centers. We added about 250 ICU beds. It may not sound a lot, but for a country that had a baseline of only 200 ICU beds, it was significant. We opened up about 100 molecular labs, making use of what we already have in terms of HIV and TB laboratories in the country. Delivered more than 4,000 oxygen delivery equipment, and also provided rapid response teams as well as food to people during the lockdown period. But I think the thing that had the most impact was probably the training of healthcare workers. We trained over 20,000 healthcare workers on infection prevention and control, and over 62,000 persons on risk communication, and close to 1 million community volunteers who were mobilized for the purpose of non-pharmaceutical interventions, etc. We also worked to expand the National Social Register to provide conditional cash transfer to about 3.6 million households. It wasn't enough, of course. It was a drop in the ocean, considering the size of the country. But we could only do what we can with the limited resources we had at hand. But it was tough. For a country where the majority of people will have to go out to seek their daily meal, the impact was significant. About 20% of workers across the board lost their jobs because of COVID. 80% of households had lost their income or had a decrease in income. Almost half of the school children couldn't engage in any form of learning. There was an increase in food items skyrocketed. The maternal and child health care services virtually collapsed. And malaria and HIV testing went down by more than 50%. And then to top all that up, towards the end, we had a significant civil disobedience. We had a hashtag #EndSARS unrest, where youth were protesting because of police brutality. So it wasn't all that easy. You can have the best of plans, but the reality is you will have a lot of ups and downs. We had issues with budgetary limitations and delayed approvals. Sometimes there was really no sense of urgency, especially when it came to the release of funds. They didn't allow the private sector to be engaged from the health side, the health clinics. They didn't trust them at the beginning of the COVID pandemic. They were worried that they will not be managing patients well. Our quarantine laws were really outdated since 1926, and we didn't have sufficient PPE at all in the country. But things eventually settled. Vaccines came through, hooray, and the president was given his first shot. He didn't change in any way. So people realized that it was probably safe if the president would take it. But we still have challenges in terms of delivering vaccines. We were able to set up a very good surveillance system, which still exists. We put out a new health protection regulations, which was signed off by the leadership. We worked with the central bank to reduce VAT and to cut interest rates. And I think probably one of the most significant things is the amount of investment that is now going into health infrastructure. A lot of treatment centers and oxygen plants and teaching hospitals got a lot more resources to improve what they already have. And I returned to the UK. Hooray. So I'm now back. I'm now back doing my clinical work, and it's really interesting to see how the interface fits between health policy and clinical care, especially at the bedside. I've also resumed my Caldecott work, which because of the COVID epidemic and changes to EPIC and the increasing role of artificial intelligence, the work has become a lot more than what it was before. But I continue to engage in international public health. I'm on the Scientific Advisory Committee of CEPI. CEPI is an innovative global partnership between public and private sector CSO, civil societies, working to accelerate the development of vaccines and enable equitable access for people during outbreaks. So a very important body. I'm also a commissioner on the Africa Commission on COVID-19. I've recently been asked to join a committee set up by the federal government to help reform the health sector, as well as the HIV Trust Fund. What was the benefit to the NHS? Personally, on a personal basis, I think I learned a lot. I learned about conflict management. I learned about dealing with difficult people, including politicians, project planning. I'm a lot more comfortable speaking to the press now and diplomacy. I've broadened my knowledge in terms of finance and national budgets and how grants are developed. I've widened my friendship and relationship networks. Whenever I fly into Nigeria, people look at me and say, "Oh, it's Dr. COVID." So, not Dr. HIV, fortunately. I think I have a greater appreciation of the the role of public servants as well, especially in the developing countries. To be honest, the pay is so low, but the amount of sacrifice some of them put in to make sure that the right thing is done. And from my own perspective as well, I can see why diversity and inclusion is so important. We have our own issues of when it comes to diversity in Africa. There are issues of ethnicity and religion, etc. And it's so important to make sure that everybody feels they are included. And from the NHS, I can very well align with the principles around compassionate leadership and the need for us to be curious, to listen to our staff, to understand the different views and mindsets, to understand and share the challenges that we all face on a day-to-day with our work. And this very much reflects the culture within the CUH. We know that it's a multicultural environment, and we're certainly not saying that everybody should just be one huge pot. We all assimilate, no. But there are universal values such as the kindness, the respect, and the being culturally aware and accepting people and being respectful of people. That's so important, teamwork and collaboration, even within CUH. And I don't know how many of you are aware of the Dill's pyramid of personal change. So to me, this really best describes my thinking and actions and how they have changed over the last 4 to 5 years. And essentially, it's a structure with separate, different layers. We have 6 layers of thinking or situations that are visualized as a hierarchy. And we have the lower levels of environment, behavior, and competence. And these are important because this is what defines where we are, when, what, and how we do things. But it's really our beliefs and values that determine what we consider to be right, what we consider to be true, and what we consider to be important, as well as our identity, because it's our identity that determines our passion, that allows for our self-actualization, and that gives us a purpose. And the purpose, of course, the purpose for most of us, we understand that we are part of something bigger than ourselves. But that purpose is what enables us to be motivated and to have a sense of self-worth and self-awareness. So what really worked? Inclusive leadership, diversity, being a good listener to your staff. These are all things that we know. Encouraging our staff to be creative and feeling the pulse, working around and making sure that you know what is happening. The Nigerian environment was especially important in that regard. We've learned a lot, even from COVID. We've learned how far you can push a swab up your nose, as this cartoon suggests. We've learned a lot about decision-making and the importance of things being managed on time, having that sense of urgency, especially in an epidemic, and also being able to maintain the balance between home and work. But what have I learned thus far? From a personal perspective, I now have a better understanding of the culture I'm operating in. I know the importance of listening and learning from the mistakes of others, because I'm continuously learning from my own mistake. And I hope this provides at least some impetus for the younger people coming. When opportunities come in, don't hesitate to say yes, but also think about what you're putting yourself into. I have no regrets for going to Nigeria. We have to learn to make the best use of our political capital and defend the rights of those that do not have a voice, and enjoy the challenge while it lasts, because I certainly did. So in summary, I've demonstrated what is possible, even in a resource-constrained environment, or if you may excuse me, we have demonstrated what is possible working as a team. We've been able to restore a struggling HIV program that was on its last leg, as seen by this slide that I got recently post the survey in 2020, the increase in antiretroviral treatment sites, the significant increase. You can see from 2007 to 2017, they went up to about 1,500. And by 3 years later, there was a significant uptick, but particularly in people being placed on treatment. 2007 to 2017, about 600,000 people were placed on treatment over a 10-year period. But over the last 3 years alone, they've put more than 500,000 people on treatment.
Dr. Sani, forgive me for interrupting you, but honestly,
we are running out of time.
We're running out of time.
I have just
we've
two
got
slides.
15 minutes. I
Yeah.
was very conscious that I do want to engage you in
Yes.
some dialogue and, you know,
Of
get
course.
a chance for people to ask questions.
I have only two slides. I'll be, I think these are the last two set of slides. So we talked about the need to work with all stakeholders to achieve a common goal. And it's also possible to learn while at the same time leading. Certainly when I went to Nigeria, I had very little knowledge of public health, but nevertheless, the learning curve was quite steep and I was still able to provide some leadership, I hope, and also working within unfamiliar environments. And we do know that the world is a global village. The NHS has a lot to offer. Skills and knowledge transfer is really critical when you want to build health systems, but learning really has to be both ways. And as the WHO chief said, we can never be safe until all of us are safe. And of course, I enjoyed it. I think you would as well. If you're given the opportunity, please do take it. If anything, you will be making a difference and you will have stories to tell your grandchildren one day. Thank you.
Absolutely fascinating insight, Dr. Sani, to your career and the opportunities you've had, and it's very, very inspirational. I'm sure Emil would agree with me. Katrina, while I don't know if there's any questions in the chat, but I certainly have a question, Dr. Sani, that I'd like to kick off with if I can, and then perhaps Emil, you might have a question for Dr. Sani. One of the things you said that struck me was about the leadership. And you said one of the main key things that you done was that the vision was aligned to the mandate, and the instrumental in turning the corner for that was the leadership. So I just wondered, obviously, in a senior clinical role that you are at CUH, what your perspective of that was for us here in CUH, for the BAME staff, in terms of how we can engage with the leadership to align, to marry up the mandate, the vision for becoming an anti-racist organisation. What are your views there?
I think that's really important, Tracy. It's a very important point you've made. At the end of the day, we have to work together with the senior management to make sure that the rest of the community within CUH understand the importance of diversity and inclusion. I believe that at the senior management level, this isn't really a major issue, but it's a case of trying, as people say, walking the talk really, and making sure that people further downstream understand the importance of this. There will be opportunities that will come up, whether it's through the BAME community or it's through other initiatives of government centrally and even at a local level. We should be more visible, we should be more vocal, and where we see things are going wrong, we should be able to stand up and say, no, this is not acceptable, this is not right. And where there are opportunities for either learning or development, we take it up and we participate. And because if you don't participate, that's the first sign that you're actually not interested, and maybe it's not that important to you either. And we all know that this is an important issue for all of us.
Thank you for that. Emil, did you have a question for Dr. Sani?
Yes, slightly more logistically with regards to the work you did when you were in Nigeria. Obviously, there's other countries during the height of COVID when it peaked in 2020. How did you work with other, for instance, West African countries such as, Ghana, Togo, Liberia, or the rest of them, because obviously there is a history of bureaucracy surrounding how they approach things, and the big challenges mentioned. There's a top heavy in most parts of African countries.
Yeah.
And those who actually do the job are very. There's not a lot of them. So how did that work in educating and supporting other countries with regards to the work you were doing in Nigeria?
I think to a large extent, the experience we had with HIV really helped. With the HIV program, for instance, we had an organization called Abidjan-Lagos Corridor Organization. And essentially, Abidjan to Lagos is a highway that goes across West Africa. And this was an organization that interrelated all HIV and health issues across the region, and was chaired by Nigeria, but the main office was in Cote d'Ivoire. And at the same time, they also had the West Africa Health Organization, which was actually headed by a Nigerian. So reaching out to the different countries within the West Africa sub-region wasn't really that difficult. In a way, we already had a working relationship with them through our HIV programs, etc. And I think if I had gone in to just do COVID without having been there 3 years earlier to do HIV, it would have been an impossible job. But when I went in, the first thing people said was, oh, it's the HIV guy who's now back. So in a way, I already had a relationship to work with. And one of the advantages of the COVID program was that it was very multisectoral. The aviation side were very strong in terms of the airports, etc., and the borders, the immigration people. So they were able to speak to each other and say, look, okay, if you're crossing the border between Benin and Nigeria, you don't need to do a PCR test because there's no lab close by. This is all we need. We just need symptom control, etc., and ask people, are they having headaches or respiratory symptoms, etc. So it was very much based on what was available. The resources were limited, but I think we made the best use of the resources. And of course, Nigeria being a huge country in West Africa always tended to dominate the picture. So if we say we think this is the right way to do things, and most of our decisions were based on advice we got that was high quality from the UK and from our US colleagues, etc. We were able to determine what happened in the rest of the region. It didn't apply, of course, to other parts of Africa. We saw what happened in Mozambique. We saw what happened in some of the Southern African countries where there was a lot of denial with COVID. But I think overall, we were already starting on a very good platform and we were able to build on it.
Absolutely fascinating, Dr. Sani. Thank you. Emil, if that's okay, I've had a question in actually from our Chief Exec, Roland Sinker. So this is from Roland, Sani, to you. And Roland says that this is all amazingly inspiring to hear. And he asks you, how do you think we can do more to bring the richness of your experience into improving how we work at CUH? From a diversity of decision-making to specifics of healthcare delivery. And that's from Roland.
So thank you, Roland, for the question. Of course, it's not easy. The trust itself needs to have people on the ground to do the work. So allowing people to go away for 4 years or whatever is not that easy. But there will be occasions when support will be required. From CUH staff, etc., abroad, especially the work that CUH has been doing in Uganda and other parts of the world. I think Burma, etc. And the skills that are subsequently brought back are skills that are really valuable, even within the NHS setup. I think we need to continue to encourage our staff to be engaged. We need those staff that currently feel that they do not have a voice to be encouraged to come out. Some of them do have skills, but unless you pull people out, as you can see from the logic, the Deltis logic that I've talked about, unless people are aware of their inner, the things that they're actually good at, but they actually don't know that they're good at it. But it's also our job, whether we are managers or we are leaders or we are at a different level, to identify those staff and encourage them to come out. If you have an interest in management, apply. Build yourself, identify yourself in terms of your supervisors and your managers, etc. Make yourself visible so that when the opportunity comes, you will have that chance of being involved as well. But everybody needs to be involved and everybody has something to offer. That's the way I see it in an organization like CUH. Everybody has a place to offer.
I think that's amazing. And again, you've touched on so many things that just resonate well with us in the BAME network and some of the initiatives that Emil, Erica and I, together with the EDI team and David Werrett and Joan Mill and Anathy, we've all been talking about talent management. And I think that's sort of, you know, where the link is for me. The talent management and the stretch assignments and the opportunities is definitely an area that we can develop. So thank you very much for that, Sani. We are very, very quickly running out of time, but if I could ask you maybe, so you referenced in your presentation earlier wish list, you know, and you'd set your wish list, and it was interesting because Erica, Emile and I know Roland's on the call, so I have to be very careful what I say here, as we've not yet spoken to Roland. We don't want to let the cat out of the bag. But, you know, we are preparing actually for a meeting with Roland coming up in the near future. And we've been actually beginning to discuss and think about all of the strategies and all of the things that we'd like to implement as a leadership team, to present as a future strategies to just start moving this mountain in terms of anti-racism. And you know, in your wish list that you referenced, it was interesting that you said you wanted to focus on your top 3 sort of priorities. So I'd like to ask you, actually, in our last sort of 5 minutes, Sani, if you had a top 3 wish list. Erica's got her hand up. Does Erica have a question in the chat, Katrina?
I don't know if she wants to verbalise her question. Do you want
to come in, Erica? I was just about to ask Sani for his top 3 wish list, but if you wanted to come in. Can you admit her, Katrina?
She should be able to. She'll just need to unmute herself to ask her question.
Okay, I've unmuted myself. Hi, and sorry that you're running late. You had a very, very lovely presentation there, so I think it just went on, and that's great. Now, my question to you, Dr. Aliyu, is that what would your advice be to a newly starting clinician from the diaspora in terms of how they can best navigate their career, given the current climate of disparity and opportunities between those of color and their white counterparts?
Thank you, Erica. That's quite a good question. So when I started off, I talked about the enablers and the people that supported me along the way. Because in life, if you're left alone to your devices, you will be making mistakes. And the purpose of having mentors and supervisors and people along the way to help you is that they have already learned from their mistakes and they stop you from making those same mistakes. If I was a newly appointed doctor or consultant coming into the UK from the diaspora, the culture I'm coming with is very different to what I'm meeting here. And I need to have people that can at least make sure that that I'm informed whatever I do. Otherwise you can easily make mistakes and end up in real trouble. Secondly, I would also like to see a situation where some of the, I know this is going to be controversial, but the feeling I have, not only in CUH, but also outside in the wider community, is that people don't like talking about race. The moment you start talking about race and identity, etc., it's an embarrassing topic to many, but it's something that needs to be normalized because we know that there are issues and the only way we can tackle them is to come forward and discuss them openly. So if we have somebody new who is coming into CUH, we identify that they're coming from a different culture, and it's our responsibility to make sure that we bring them in. We're not asking them to change their culture, because you can't ask somebody to change his or her culture, but their values and their beliefs, etc., need to at least align with some of what we believe is right, and to help them and support them and understand that there will be mistakes along the way, but to support them and make sure that if they are having concerns, those concerns are at least alleviated. And there are bodies, even within the BMA, the British Medical Association, etc., and within our own organization setup, the BAME network, etc., there is support that people can seek out for. But I certainly wouldn't come in solo and just work without connecting with people that I know can help me along the way. Everybody needs support and help in their career.
That's amazing, Sani, because actually that's Hashim Mohammed touched on very similar elements in his presentation yesterday, but he spoke about it in terms of social currency, and that particularly people from the diaspora and BAME origin lack that. So even if you're heavily educated, the introductions, the enablers, access to the enablers, and the elements that you're talking about there actually plays a massive contribution to how well your career progresses. And that again links into talent management, and one of the things that, you know, as the leaders in the BAME network, we are definitely wanting to tackle. But we've got literally 1 minute left. Sani, I'm really keen to just get from you your 3 top tips. So you're reaching out here, your audience is to all of the BAME staff in the organization. What 3 things can you give us as by way of advice in terms of how to progress our career?
So probably the first bit I would say is be sure of yourself, really. Develop a sense of self-confidence. It is all right if you do not know something, it is all right if you do not understand a culture, but know that within yourself, that you are somebody as well. And I'll give you an example. Like when I came to the UK, I had a friend in the lab and he was going on holiday and he wanted to climb mountains. And I looked at him and said, "Are you mad? Why should you climb a mountain?" And of course, the culture was very different. In Africa, we don't start climbing mountains, but over here, when you go on holidays, you climb hills, etc. And to him, it was very funny. But to me, I was actually saying it from the bottom of my heart. So first of all, at least having that belief in yourself. Secondly, having the support that you need and know where to go looking for the support. And then the third thing is making sure that the organization itself has policies and systems that discourage people from engaging in unacceptable behavior against people that look different. Those are the 3 simple things that I think in a way would help somebody to at least in the first 5-10 years of their career be able to come to work, feel happy, know that they have contributed something, and go back home as well.
Amazing, absolutely amazing. Emil, did you want to say some parting remarks to Dr. Sani? You're muted.
No, just to say thank you very much for your presentation, and it's inspiring. The last words, the top tips, I think are very much more hits the point. So yeah, thank you very much, and it's been very informative of what you've done, and you know, assisted that part of Africa in addressing the pandemic itself, and in creating a lot of development and advancement in the health service over there. So, and bringing that back and encouraging us as BAME, minority ethnic people, to look at that and build on that. So thank you.
Thank you. Thank you.
Absolutely incredible, Dr. Sani. Thank you. In the chat, there's lots of love for you. So all of the people sort of on the call, sort of just sending thanks and gratitude, and just letting you know just how actually really truly inspiring you are. And you're such an asset to us as an organization. And I'm putting this out to you personally, Dr. Sani. I want to see you at our BAME network meetings a lot more. You are a resource that's, you know, we're not rinsing you out, nowhere near enough. So, you know, we'll be talking to you about that separately, but it's been absolutely fantastic, you giving up your time today to join us. I'm ever so grateful. I'm privileged to know you. And thank you so very, very much indeed for your time today.
Thank you, Tracy. Thank you, Emil, as well. And thank you, everybody, for listening.